Srinivas, please go ahead.
So good morning, everyone. So this is about CRRT in ICU part 2. We have discussed part 1 previously. So there will be a revision of some topic and there will be a discussion of the further topics also. So we'll start with okay. So we have already discussed about the terms, what are the things, what we'll do, what are the circuit, everything we have discussed previously. Now, the indications we have discussed previously, but just for a revision, we'll revise what are the indications. So indications can be broadly divided as renal indications and non-renal indications. So coming to the renal indications, progressive azotemia patient not responding with the conservative management, and his urea is being increased. And what I'm talking about AKA, not about CKD. So these symptoms, uremic symptoms, not patient. We don't let the patient land up in pericarditis or neuropathy and all those things. But initial symptoms such as vomiting, nausea, and slight onset of altered sensorium, all those things gives an indication that the patient has to be dialyzed. And irrespective of the number of the urea, it might be 70 for one patient, it might be 100 for one patient, it might be 120 for one patient, depending on the toleration of the patient. So there is no clear cut guidelines that this has to be the uremia has to be dialyzed at this point of time. And AKA obviously depends on the stage of the AKA as defined by rifle criteria or Aiken criteria. You will go and dialyze as per the required indications. Third, already we have discussed the progressive ischemia, and fourth, it is volume overload or diuretic resistant oliguria. And when there is no urine output and the patient is having increased requirement of oxygen with the worsening of your respiratory, worsening of the respiratory parameters, then obviously we'll go for a dialysis. These indications, what we are talking about CRRT, I need not to be in case of a case of CKD. So fluid overload patient can be even presented with shock. Or the patient might have oliguria and the patient might have increased oxygen requirement because of the oliguria. So these patients may be started with scuff, which is the one of the modality in CRRT. And other criteria that has electrolyte imbalance. So it is mainly hyperkalemia. So in CRRT, if you want to deal with the hyperkalemia as your target and you have initiated because first reason is of hyperkalemia, you may have to go for a higher effluent doses rather than going for a lower effluent doses, because the potassium clearance will be, as potassium is soluble both in blood and plasma erythrocytes, its movement in and out of erythrocytes is easy. So which gives a positive point that it is cleared both by dialysis and by ultrafiltration. So you can use combination of both with a higher effluent dose to get potassium cleared. Other electrolyte imbalances, what we can deal with are hypernatremia, where as a resistant hypernatremia, where your sodium levels are not getting stabilized with your normal conservative management, or hyponatremia. Even you can have a graded manner of increase in the sodium concentration when the patient is not responding, or resistant hypercalcemia, where the calcium levels can be lowered by increasing your dose adjustments. And the last but not the least, metabolic acidosis, where your patient has to be dialyzed because the metabolic acidosis is resistant to whatever the conservative management that you are giving. Coming to the non-renal indications, the most common and the bread and butter of the Indians, which is sepsis, where the sepsis-related AKI rather than sepsis-related AKI, and the patients are more treated with CRRT with a extra filter, that is either it is a cytokine removal filter, either it can be a cytosorb, or it can be auxiliaries, or it can be a toromixin filter, which you attach. These cases are mostly seen in case of sepsis. And next thing is for ammonia clearance in case of acute liver failure, where you have to go for CRRT rather than an intermittent hemodialysis, because the production of urea is constant and continuous, and depending on the damage that liver has been underwent. So when the patient until unless the patient's liver recovers, the production of ammonia, rather than you say the metabolism of ammonia is decreased by the liver, and you have to go for the continuous dialysis for the removal of ammonia, and it is soluble molecule, and it can be removed both by dialysis and ultrafiltration. So and it doesn't require, it is a very small molecule, and it doesn't require much of the pore size. The other things like congestive heart failure, when the patient is having chronic LV dysfunction, where the patient is not able to tolerate higher dialysate flows, those patients have, irrespective of the hemodynamic status, the patients obviously maintain a BP of 100 or 90 systolic with a mean arterial pressure of 65, 70, even though you can increase their BP with noradrenaline, but it's better to go for a CRRT, because the solute removal should be slower in these cases. Even the patient might be on 3 ml to 5 ml of noradrenaline, 3 to 5 mics of noradrenaline. Even then you have to go for a CRRT, better with a valvular disease in addition to a chronic LV dysfunction. Fourth, it is ARDS, where you need equibalence or slightly negative balance, not a complete negative balance. It's a slightly negative balance where you have to achieve, and even the literature says continuous removal rather than a intermittent hemodialysis with ARDS with AKA gives a better physiology that as compared to intermittent hemodialysis. And rhabdomyolysis causing ATN, acute tubular necrosis, and contrast-induced AKA. So contrast, obviously, it is not dialyzable, but the previous guidelines, whatever they say, to prevent the injury, it's better to use CRRT peri-procedural, starting prior to the intervention, continuing throughout the intervention, and continuing it post intervention also. So it might help, but it is not proven that it might help. Recent studies doesn't show that there is a definite proven modality that it can prevent AKI, contrast-induced AKI. Obviously, when the patient's blood is removed from the body and it is being sent into circuit, there is a loss of temperature and causes hypothermia, so which can be used as a treatment purpose for in case of refractory hypothermia. Patient is not getting improved with conservative measures of temperature management, such as like sponging, antipyretics, NSAIDs, or cold IV fluids and bladder lavage, whatever you say. And when the patient is not responsive, and the patient is having other issues like TBA and all those things, where you have to prevent your hyperthermia. So those things can be better managed with CRRT. And in severe acute pancreatitis, it is like continuous inflammatory state, where there is continuous release of cytokines or inflammatory mediators, which causing AKI. So it is useful in case of severe acute pancreatitis. And coming to abdominal compartment syndrome, where one of your modality of choice for further treatment of abdominal compartment syndrome after your cavity emptying after your tube, flatus tube insertion, and after in removing the collections in the abdomen, patient sedating and paralyzing the patient. After removing all those things, and the patient is cannot be diuresed using a diuretic, cannot be achieved with a negative balance. In those patients, you have to go for a hemofiltration technique and for the fluid removal. And the other option with CRRT machine is therapeutic plasma exchange, where you can do high volume plasmapheresis continuously for 7 to 8 hours in case of acute liver failure with hyperbilirubinemia. So high levels of hyperbilirubin, the levels can be drastically reduced with therapeutic plasma exchange, and the ammonia clearance can also be achieved to a very great extent with therapeutic plasma exchange. And it is also mostly useful, especially in case of autoimmune kind of acute liver failure. And the list goes on with drug overdose or poisoning, where there are a number of poisons where dialyzable drugs and poisons, such as ethanol, methanol poisoning, where you can remove, you can dialyze the patient and get treated. And the other indication is extracorporeal removal of CO2, where you can use pediatric oxygenator of ECMO and in connection with the in connection with CRRT, where you can remove CO2 extracorporeally, where the patient is having ARDS and AKA, which patient is on CRRT and on a higher level of CO2. So those patients definitely benefit, and there are the literature coming on these extracorporeal removal of CO2. But as per the theory or the physiology, it gives a better lung rest as compared to without say extracorporeal CO2 removal. So coming to the timing, obviously it is a different issue that when there is a absolute indication for dialysis, that is a hyperkalemia or metabolic acidosis, or some absolute indication where you have to do CRRT, where you have to do a renal replacement therapy. So those in those cases, there is no controversy that it should be done earlier, it should be done late. And it is for the patients where you have deranged RFT, progressive increase in the creatinine with not complete oliguria. The patient is producing urine output, and there is slight amount of metabolic acidosis, but it is not worsening. So there is a dilemma that the patient has to undergo, say, a dialysis or not. In those cases, is it better to go for an early dialysis, or is it better to go for a late dialysis? So there are a number of studies. So most importantly, what we can talk about 4 studies: Alien trial, Akiki trial, Ideal ICU, and Start AKI. So Alien and Akiki. Alien, if you talk about Alien trial, it is mostly of surgical patients, and it has not separated or not excluded category of absolute indication for dialysis. So which probably might give an impression that early dialysis might improve, is better with a better hemodynamic tolerability or better outcome and about mortality difference. But on rest all of the trials, Akiki, Ideal ICU, and Start AK are taken consideration. All the sick patients or the critically ill patients with the AK stage 2 and stage 3. What early means, it is initiation of the dialysis in AK stage 2. For different persons, they have started from 6 hours at the earliest to 12 hours at the earliest. So this is considered as early dialysis, and as compared to late dialysis, which everyone follows, that it is AK stage 3. Stage 3 of rifle criteria. So when so all these three trials doesn't or didn't show any mortality benefit or benefit in case of or in case of what do you say is length of the stay or oxygen requirements. So there is no much of change in AKK, ideal ICU or START AK. START AK is one of the recent trials and which has taken some 2000 patients into consideration, and even it has given no mortality benefit even if you do early or late, whatever, it doesn't matter. But in the best part is START AK trial has taken consideration, like 70% of the patient has received CRRT and 30% has received intermittent hemodialysis. So when you have a diagnosis of AK and when there is a life-threatening complication of AK, that is hyperkalemia, refractory acidosis, or intoxication, that cannot be reversed by simple means, obviously you have to go for a dialysis. So RRT has to be pertinent. So if is there any reversible cause that can be, there is no life-threatening complication of AK and there is a chance of reversibility of AK. So reverse hypovolemia unless contraindicated, we have to optimize the fluid status and discontinue or avoid the offending agents. So regular assessment of the clinical status has to be done. Your assessment of the worsening of the RFT, your fluid balance, your oliguria, and the response to resuscitation and the acid burst profile has to be judged clinically every 12 hours to see if the patient might require a renal replacement therapy. So when there is persistent or worsening AKI, or there is evidence one of the more of the following, like accumulation of the fluid, worsening of the oxidation, or worsening of the acidosis, worsening of hyperkalemia, or worsening of oliguria, worsening of the non-renal dysfunction, and significant fluid or solute burden, so you have to go for a dialysis. If it is if the patient is hemodynamically unstable, then you have to go for a continuous thing, and if the patient is stable, then you have to go for an intermittent renal replacement therapy. So when you have started your dialysis and you have continued with for some time, and so when you have to when you have to stop the dialysis, so obviously there are different trials and studies which have taken many criteria into consideration, and but everything came to be futile. So in a simple words, in 2012, when KDIGO guidelines have given those things, they simply say, so stop the dialysis when not needed. It is a clinical or physician assessment which is the final thing that is deciding the patient who have to be on dialysis further, or who doesn't need any dialysis. So they have studied many parameters, but out of the some parameters which has it is both of what you say as clinical condition and lab parameters. So when you come to the clinical condition, if the patient is having persistent hypotension or hemodynamic instability, and you are suspecting that the patient might need 2 to 3 more days to recover, so obviously the patient has to be continued with CRRT, and the patient renal recovery has not been attained and not been started. So it obviously you have to continue your CRRT. So even if you think that the patient is producing 10 to 15 ml of this thing, and the acidosis has been corrected, and problem is when you see the lab parameters, creatinine or urea, it get normalized, but it is not the function of the kidney, it is function of the dialysis that you are doing. So with a false opinion that the kidney has recovered, you might stop the CRRT, and we may land up in reinitiating a dialysis for the same patient, and it might be CRRT or intermittent hemodialysis. So which you call it as a failed stopping of the CRRT. So obviously you have to judge it twice or thrice before stopping the CRRT. When there is a simple recovery, that when you see obvious recovery, the patient is producing around 1000 ml or 1500 ml of urine output, and the acidosis has been corrected, and patient's vasopressors have been weaned off, and the oxygen requirement has been improved, and the clinical conditions or the other parameters, other supportive parameters, you see that the patient has been improving. Obviously, you can stop the dialysis. But when you see that the urine output is like borderline, borderline in the sense that is above 400 ml. So you might think of stopping or non-stopping. Obviously, it is a decision of confusion. So in those cases, they have taken some parameters. One is like urine output. After stopping of the dialysis, when the patient is having more than 400 ml of urine output post stopping of the dialysis in the next 8 hours, it is an indication that the patient might not require CRRT for in next 48 hours. They have taken creatinine clearance as one of the modality, but nothing has proven a single criteria. And the third thing which they have taken into consideration is the biomarkers. Biomarkers, we need a biomarker which should not be removed from the filter, because if it is removed from the filter, what we get the value of the biomarker is the efficiency of the dialyzer, but not the efficiency of the kidney in removing the solute. So one of the biomarker what they have taken is NGAL. So it has showed some criteria or some benefit that where to stop CRRT. But when it comes to the finances and logistics and all these part, when everything has taken into consideration, the restarting of the dialysis is as expensive of using NGAL as a biomarker. So there is no point in using for every patient as NGAL is a biomarker, because of it cost benefit ratios and the percentage of the benefit it is showing for stopping of the CRRT. So coming to the dose, what we have to use during the CRRT, how much effluent dose, what you say as effluent, which means either it is a dialysate in case of hemodialysis or effluent in case of replacement in case of hemofiltration, or combination of both with extra fluid removal in case of CVV HDF with an extra fluid removal. So this is measured as ml per kg per hour. So it is totally dependent on how efficient your CRRT is in giving a KT by V value of more than at least 1.2. So because of which you manipulate your dose. So everything is related to KT by V, where your K is constant and time is the duration of the dialysis that has been going on, and V is the volume of distribution of the solute. Generally, we talk about the urea. When your target molecule changes, your volume of distribution changes. So you target a single molecule and you change your KT by V values accordingly. So as per the KDIGO guidelines, the KT by V value at least should be at least 1.2. So what is how you calculate the effluent dose? So obviously, when you are, it is the fluid that is coming from out of the circuit. So in case of CVV HD, we think in every modality we are removing some kind of extra amount of fluid. In case of dialysis, two things are coming out. One is dialysate and extra fluid removal. In case of hemofiltration, so it is replacement fluid and extra amount of fluid. And in case of hemodiafiltration, it is dialysate plus replacement plus the extra fluid removal that you are using. So by averaging these three per kg per hour, you will get your effluent dose. So it is easy to calculate, and even CRRT, when you adjust your dialysate flow and replacement flow and extra fluid, automatically it gives your value of effluent dose. So if your effluent, what is you have to do with the effluent, either it is a high effluent dose or the low effluent dose. So, and there are many studies which shows which have been done, which is more efficient. So ATN and the renal studies, they have taken consideration the effluent dose of 20 and 35, which is low and high, and the renal has taken like 25 and 40, which is low effluent dose and a high effluent dose. So when you come, so they have seen that low effluent dose is as good as high effluent dose. But a later study, DOREMI trial, which has taken the some of the parameters such as stopping of the CRRT for fluid changes or bag changes or some kind of alarm issues. When these causes your decrease in the dose that has been prescribed, there has been a change in the dialysis that has been given to the patient. So it has given a guideline that the effluent dose has to be increases slightly to compensate all these things. That it has to be 25 to it should be like 30 ml per kg per hour. But Kidigo again simply given a statement that irrespective of anything, 25 ml per kg per hour, an initiation dose of effluent is good enough to take care of all the needed solute removal. But obviously we have to understand it is a dynamic change that what we have to do in ICU by an intensive. It is, but even though we start with a dose of 25 ml per kg per hour, but if the patient is having a higher urea or hyperkalemia, or the patient's doses is higher, and you need to achieve a better clearance of the solute, you have to increase your dose in the as per the tolerance of the hemodynamics. And when your H-doses clearance is good and you have to reduce your effluent dose, it has to be in a dynamic way, and it is not a constant dose that has to be continued for a better quality of the CRRT that you are giving. So obviously the recommended and the reported gap, that it should be less than 20%. The prescribed effluent dose should be and the delivered dose should be at least less than 20%. And you can measure the efficiency by either by clearance more than 0.8 or dose prescribed, whatever the amount of dose you have prescribed, the ratio should be more than 0.8, or CRRT time should be more than 80%, or the solute control formula what we can apply. So you have to maintain your time at least more than 80% or achieve a dose of more than 0.8. So coming to the anticoagulation, what you use in case of CRRT, we start from unfractionated heparin, and it ends with nafamostat, the drugs you are giving. All these things that you are giving systemically. It is not, and some drugs can be given in circuit. But even if you give in circuit, even though you are not giving IV and you are giving through the circuit, some part of the drug will be entering definitely into the blood, which will be causing the damage. So regional anticoagulation with all these things can be done, and systemic anticoagulation can be done. But the effects of systemic anticoagulation will be much worse as compared to regional anticoagulation. So if you come to the half-life, the highest half-life will is with denaparanoid, which has 12 hours, and as compared to nafamostat, which is prostacyclin, which has very least half-life of 2 minutes to 6 minutes, which gives an advantage that if you have any bleeding complications, it can be reversed just by stopping the infusion for just 10 minutes. So the doses can be adjusted accordingly and as per the parameters available. So APT, ACT are generally monitored, and for LMWH as anti-tenia available is very difficult to assess. So we'll go with the clinical condition rather than going for a lab parameter. And so going for a regional anticoagulation will be better in case rather than going for a systemic anticoagulation. And your reversal availability also gives a good indication that which has to be continued, and as per your institution's availability of the reversal drugs, you can go for which anticoagulant you can use. So it's better to go for a drug which have like low half-life and which doesn't need any reversal. So coming to the citrate is one of the best anticoagulation where we can use as a regional citrate anticoagulation. Out of all the systemic regional anticoagulation, this is one of the proven thing which has a very good filter life, and with adequate management and with adequate monitoring, you can increase your life to 3 days or 4 days, which gives you a good thing. And the logistics are also available accordingly. The solutions are also available accordingly. Whatever you need is a skillful person at the bedside, and an ABG and a calcium value with solutions. That's and everything is possible at any point of center or any point of time. So what are the two solutions that you use is Rizocit, which contains citrate anticoagulation, which you use pre-filter or pre-blood pump. It also acts as a replacement fluid. So both it acts as a pre-filter replacement with an anticoagulation. Obviously, when you are using a anticoagulation, you have to be using it as a pre-filter dilution rather than a post-filter dilution. And the second solution, what you use Rizocit is bifosil. You use bifosil as a replacement solution or a dialysate solution, because you have to use a solution which doesn't contain calcium, because your citrate mechanism is based on the calcium chelation or the calcium binding, which is one of the main like molecule for in your clotting mechanism. You inhibit, you stop your calcium, you bind your calcium, your anticoagulation process will be will be stopped. So obviously the blood will be in a anticoagulation state, or its coagulability is decreased. So in case of citrate, what you have to do is you start with you have to achieve a value of around 3 millimole per liter of the citrate in blood to make it or to achieve the anticoagulation properties of the citrate. And what is the most common problem is it is binding to the calcium, and out of which 65% or 70% of the citrate solution will be coming out of the circuit, and around 25 to 30% of the solution will be going into the body. So obviously even this solution, this regional solution, will also have a systemic side effects, but adequate monitoring of the calcium levels and the ABG levels and the alkalosis or acidosis will prevent you such complications. And citrate can be talked in terms of three things: citrate accumulation, or citrate overdose, or citrate toxicity, and which is a very last topic to discuss. We will not be discussing in this forum. So what you have to monitor your ABG levels to see any worsening accumulation, or your ionic calcium is being decreased, and you have to see the ratio of the normal calcium with the ionic calcium, and any ratio more than 2.5, which gives the indication that the citrate overdose is being done. And the patient who has received citrate anticoagulation in case of therapeutic plasma exchange, the most common complication what you see is metabolic alkalosis. And the patient is having a citrate toxicity, you will see acidosis rather than alkalosis. So worsening acidosis, unexplainable acidosis unexplained worsening of the acidosis and ABG in a case of citrate anticoagulation. Just think of citrate toxicity. And a patient is having alkalosis post the procedure, post citrate anticoagulation, is possibility of citrate accumulation. So these things, in these things you have to stop your citrate anticoagulation. Coming to the pharmacokinetics and dynamics in case of CRRT. So what is the main concern in pharmacokinetics and dynamics? Is it the drug dosing, or underdosing, or the overdosing? So obviously we are concerned about the antibiotics rather than anything. It is the adequate concentration of the antibiotics that has to be delivered in case of CRRT, because mostly it is underdosed rather than overdosed. Because as the creatinine is increased, and we adjust the antibiotic depending on the creatinine dose. But in AKA, it definitely with creatinine value doesn't give any status of the GFR. So the clearance difference is there and there is a delay in case of biochemical and lab parameters. Clinical and the lab parameters, sorry. So obviously your concern is about underdosing. So how will you adjust your dosing? So factors that potentially affect the drug clearance in CRRT, either it can be a drug properties or the device properties. When first thing is a molecular weight. When you come to the molecular weight, any molecule is removed in CRRT by either by diffusion or convection. If you use diffusion, it is depending on the pore size of the filter and the concentration gradient. If the the most of the drugs are not very easily uh, um, removed by process of diffusion. The main process is convection, where there is a force that has been used. It is a pump driven pressure gradient, and it is unconditioned by the drug molecular weight, and it is very rapid. So your clearance is very high in case of convection. So in the patient who is undergoing hemodiafiltration will have a very high clearance as compared to hemofiltration, as compared to intermittent hemodialysis. So the patient who is undergoing hemodiafiltration, your doses should be obviously high. And if you compare to the molecular weight of the pore and size of molecular weight and the pore of the filter, so the largest molecule, if you can see the quinprisin, alpha-prisin, teicoplanin, and vancomycin, and colistin. So the maximum values that value of the molecular weight is 2000. Whereas when in case of CRRT, the pore size, the maximum size which the largest molecule which can be dragged out is up to the size of 30,000 Daltons. So there is a vast variation in the size of the size of the molecular weight of the drug, and as compared to the size of the pore. So obviously, irrespective of the size, any drug is removed from CRRT. So the clearance is very high, obviously. So any patient on CRRT, you have to increase your drug dosing. So how much it has to be increased, that we'll decide on. When coming to the plasma, the other factor of drug property, it is plasma protein binding. So when your drug is more bind to the plasma, so your free drug availability is less. So obviously, when your it is the filter membrane is impermeable to albumin, and albumin bound substances are less cleared in case of CRRT. Whatever mechanism of solute transport you take into consideration. So you have to see the property of drug binding when you are adjusting your dose. Third thing is volume of distribution. When you come to the volume of distribution, you can obviously divide your drugs into two kinds, which is hydrophilic and lipophilic. Hydrophilic are mostly beta-lactams, penicillins, cephalosporins, carbapenems, monopeptides, glycopeptides, and aminoglycosides. And the lipophilics are macrolides, fluoroquinolones, tetracycline, chlorophenicol, rifampicin, linezolid. So what is the difference between hydrophilic and lipophilic in case of CRRT? The volume of distribution is limited, and mostly hydrophilic drugs stay in intravascular compartment. They are water soluble and they stay intravascular compartment. They don't go to the fat soluble compartments. So because of which your volume of distribution is low. So when it is more freely available in the blood, it is easily cleared by the dialysis, cleared by the dialysis filter. So any hydrophilic drug, you have to increase your dose. And mostly when you are all the hydrophilic drug, by default you have a renal clearance. As compared to lipophilic, their volume of distribution is very high, and there is freely processed through plasma membranes into the cells and active, and because of which property it has it is active against intracellular pathogens and eliminated by hepatic metabolism rather than a renal metabolism. So obviously your renal clearance is low, and it is not easily excretable from the CRRT. This thing. Obviously, there are exceptions for both of these things. you take into consideration of like ceftriaxone or oxacillin, where your metabolism is by liver rather than by the kidney. And if you take fluoroquinolones, levofloxacin and ciprofloxacin have renal clearance rather than a lipophilic clearance. So you have to take into consideration which type of drug it is and the volume, what is the volume of distribution before you take any decision on the adjustment of the drugs. And the proportion of the renal clearance, as we have already discussed, which have a very good renal clearance, obviously it is easily excreted by the kidney. And coming to the device properties, your composition of the filter, surface area. So when you have a larger surface area, your excretion is increased and the pore size is larger. So obviously, in case of normal dialysis, you have a normal filter which doesn't have a high flux dialyzer. So in CRRT, you have a high flux dialyzer. Your pore size is large. So irrespective of your drug size, it is being dragged. And if you are using on a normal machine, you are using an adsorptive technique to remove any poison or drug intoxication thing. So obviously, it have a better clearance and drug clearance as compared to normal filter. So based on these properties, you have to adjust your drug dosing. So the factors that potentially increase the drug clearance during renal replacement therapy are hemodiafiltration and the high volume ultrafiltration, where your drug clearance is higher. If you come to the patient's pathology, when the patient's albumin is low, your drug availability is high, so clearance is high. In a case of hypoalbuminemia, your drug clearance is high. And the patient's residual renal function, that is, if the patient is having innate urine output of around 40 to 50 ml per hour. So obviously the drug is getting excreted through urine, normal kidney also. So in addition to dialysis clearance, you have a normal renal clearance, which obviously your dosing becomes very like underdosing happens in those things. So what are the drug properties which has a highest potential for clearance? Low molecular weight, low plasma grinding, low volume of distribution, and the high renal clearance. So these are the things what you observe. So obviously, how will you adjust your dose? So in case of a drug which is like having a Cmax, Tmax over the concentration, you have to maintain your drug intervals, and you have to increase your drug doses intermittently. In the sense, if you are giving a 500 milligram of meropenem 8 hourly, you have to maintain your frequency in the same level, and you have to increase your drug doses to either 1 gram, or if required, you can increase your frequency to 6 hourly, and you can maintain your dose. Or you can, if the patient is having a innate urine output, you can increase your dose maximum to of 2 grams 8 hourly, that is at up to a dose of 6 hourly 6 grams a day. So starting from a dose of 1 gram or a 1.5 gram a day to 6 gram, depending on the type of modality that you are using, and the patient innate renal function, and the patient albumin protein status or the albumin status. So if you compare same thing, where if you compare a drug which is having mechanism like concentration max more than the time, you have to achieve a level of more than 8 to 10 times of the MIC. So in these cases, you have to give the same dose, because to maintain the concentration, you have to give for example, you take into consideration an amikacin, so you have to give a 750 mg of the dose, but instead of you giving a daily dose, you have to give an alternative dose. That means you have to increase your frequency interval rather than decreasing the dose. So when you take all these into consideration, and you have to adjust your dose as per the improvement of the patient. On the first day of the CRRT, the patient might have been alguric and your effluent dose may have been high. So, and might be the effluent dose you are starting is low. You have to decrease your dose. And if the patient on the third day of CRRT is having a urine output of 30 to 40 ml per hour, and you are increased dose to 40 to 45 ml of effluent dose, So your drug clearance is high, and obviously you have to increase your doses. It is a daily or a 12th hourly thing what you have to change your doses as per your patient's hemodynamics, rather than giving a constant dose on CRRT. That, thank you.
Thank you, Srinivas. Very good presentation and very extensively explained on CRRT indications and the dose adjustments of antibiotics. So once regarding the dose adjustments of CRRT, usually we are checking the creatinine clearance, and we are making almost a fixed dose depend on the creatinine clearance, and we are not adjusting the daily basis, as you said, depends on the urine output and daily creatinine clearance values. So once you start, we are continuing for a few days, whether patient is dose is okay or not.
Yes,
So what is yeah? Can you explain more clear on this dose adjustment on CRRT?
sir, anytime problem is the creatinine clearance values are for the static kind of status, a static kind of creatinine, and the creatinine clearance we should not measure in case of AKI, and there is no actual measure which can measure the GFR in AKI. So the whatever the possible logistics that we are having, and the patient is having augmented renal clearance in case of sepsis, and the patient is having a shock hyperdynamic circulation with two stages, you can say, as worsening AK or a recovering AK. When the patient is having a worsening AK, your creatinine might be 1.5, and your output is only 10 to 15 ml per hour, and you are having a metabolic acidosis where you are about to start a dialysis. In those cases, your normal creatinine, the creatinine might be like a 2.5, but you are getting a lab value of 1.5. In those cases, you restrict your doses. That means take it as like I mean, if you suppose commonly carbapenem, when you take as meropenem, so you just take as 10 500 mg TID. And when you start when the patients start to have a recovering AKA, so in those cases, when the patient's condition is recovering, the patient is producing urine output, you start increasing your dose. And if you are in case of a worsening AK, if the urine output is on the borderline, right, like you might be having a creatinine of 2.5 and the patient is producing around 50 to 60 ml of urine, so you go for a higher dose. Rather than 1.5 gram, you go for a 2 gram per day dose. Exactly at which concentration, which value has to be, which doses has to be given, that only decided by the therapeutic drug monitoring, which is not very possible in Indian setups. So therapeutic drug monitoring is not possible. So with that only we can exactly adjust our dose. But as an assumption that the patient's creatinine or like clinical condition is improving, you go for a slightly higher dose. And if the patient is on CRRT, you go for a maximum dose, what the drug can be given. If you can take as a ticoplanin, you can adjust your dose up to 800 mg per day. If meropenem, you go for a 6 grams per day. So all these things depends on depending on your molecule size and type of dialysis you are using. So exact dosing that nobody can say, because lack of the therapeutic drug monitoring.
Yeah. Any doubts from others?
Srinivas, thank you for your elaborative class and immediately exchanging and doing it. So I request you to post this presentation in a reflect delegates group, so that it is something, if they are missed, at least they'll be benefited. Number one. Number two, as you said, KDIGO guidelines, they have been asked to start 25 ml an average of for everybody. And as you said, it is going to change accordingly when you are using it at the bedside. So is it because that not only the therapeutic guidelines are there, or Cochrane's formula, whatever is there, and that is the reason they have given that guidelines, or is there another evidence for that? And the last third question is that, as you said, like in a monitoring of CRRT, or what is the important things to monitor when the CRRT? But these are the 3 points from my side. Thank you.
Sir, I didn't get your second question.
First question is to reflect delegates group లో ఇది పెట్టడం. Second
okay.
question is 25 ml to start with CRRT చెప్పారు కదా మీరు.
అవును సార్.
కేటగిరీ గైడ్లైన్స్ ప్రకారం.
ఓకే.
అంటే వాటి డిఫరెన్స్ ఏంటి, దానికి ఎందుకు ఇచ్చాడు? మూడోది నేను చెప్పాను కదా, అర్థమైంది కదా, రైట్.
So second question is like 25 ml, how it has been given. Obviously, it is been given on the level of KT/V value. So with 25 ml of per kg per hour effluent dose, you can achieve your KT/V value of 1.2 for a patient who is requiring the indication of urea clearance, urea as a clearance solute, that molecule that you are targeting. So that's why every dosing is based on the is referred to a standard value of KT/V. So if you can get your KT/V value on the bedside or the solute efficiency or the solute clearance value, you can increase or decrease your dose daily. Some patients might have a hypercatabolic state and a higher production of urea. So in those cases, you might have to go for a higher dose. But when they have taken an average set of population, 60 to 70% of the population, your 1.2 can be achieved with a dose of 25 ml per kg per day.
Srinivas garu.
Sir, cheppandi.
Something related to the dialysis, maybe not particular to CRRT. I have a doubt, and regularly I am confronting with my nephrology people.
Sir.
Patient is in septic shock. We know that patient is hemodynamically unstable and creatinine is high, metabolic acidosis. We instituted dialysis in that patient, either a SLED mode or CRRT mode. Mostly it is a SLED mode. Okay. So in that patient, the next day creatinine is going up. Second day also, first day they say that, no, we have only dialyzed it just for the sake of dialysis to introduce to the patient. Parameters may not be coming to the normal. Next day the dialysis, still the creatinine is going up. Then my argument is why your dialysis is ineffective. So they say that the catabolic process is going on. So still there is a lot of creatinine production. Though we are dialyzing, we are not bringing it to down. Is it true?
Yes, definitely true, sir. Definitely true. When the patient is having a higher catabolic state, that is why a CRRT is more preferred than SLED, because it takes the time, continuous production of the creatinine or the metabolism into consideration rather than just a solute removal. So in any way, when you take a physiological basis, your hypercatabolic state produce higher amount of this thing, and the muscle breakdown, whatever you causes, you name it, you have a hypercatabolic state, you need a higher dialysis. So the problem with the initiation of the first dialysis is the patient will not be able to tolerate in case of normal dialysis. So that gives a option that you have to go for a second dialysis or the third dialysis. That is completely true, sir.
But how do we have a check on whether their dialysis is properly doing or not?
That actually you have to see the solute effluent. If in case of CRRT, if you see the effluent solute dose, effluent solute this thing, then you can see what is the solute concentration in the blood and what is the solute concentration in the effluent. Then you will able to know what is the exact amount of solute clearance that is been going on. So that in that way you can go for an efficiency of the dialysis.
Sir, this can I add?
Sir,
Yes, sir.
Sir, this depends on as you are going on a sled. So how many hours is done? What is your dialysis flow rate? What is the blood flow rate? So it depends on all these factors when the sled is going on. So these three factors mainly. If your blood flow is low and you are doing for 3 and 4 hours, because as your patient is hemodynamically unstable, the clearance will not be good. And if your blood flow is high, as they do in regular routine dialysis, then around 300 to 400 they put a blood flow. In that condition, the adequate clearance
rather than blood flow, it is the dialysate flow that gives a better clearance, because what we can achieve is so this thing. And even if you go for 8 hours, as Satish sir said,
more catabolism, but at the same time, as Satish sir mentioned,
Sir,
Even
Srinivas sir,
after
not audible. Jay
sir,
Srinivas sir, not audible.
So go in the opposite direction. So both, sir. Sir, hello, sir. Am I audible, sir?
Yeah, now.
Hello?
Yeah.
Sir, as Srinivas is mentioning, the dialysate flow, but here both is important. Both the blood flow and dialysate flow, both is important in a patient with a SLED for the clearance. So it depends on blood flow, dialysate flow, and also on the number of hours. So 3 are important factors, sir, in SLED.
So actually, I have checked on these things. We used to do SLED normally up to 8 to 10 hours. We give a prolonged SLED period, and the ultrafiltration is very minimal, and dialysate flow is around, like blood flow is around 100 to 200 ml because hemodynamically unstable. From my side, I am checking all these points, and I am arguing with my nephrologist saying that his dialysis is inefficient. Because no, even after dialysis, there should be at least the normal value, or normal is where I started with my creatinine. Maybe it is 10 or 12. Now, even after dialysis, it's going to 15. So what is the point in dialyzing this patient?
Sir,
so
sir,
you
you
get
were
the same thing. You can get your UF, the UF that is removed. You can check the solute concentration on that, and you can exactly go for how effective it is. You can have a better evidence based this thing answer.
Can we check your serum NCAL or any markers to see whether your dialysis is efficient or not?
Sir, dialysis efficiency cannot be assessed by NGOL because it is not excreted by filter.
Then
sir,
as
but
Satish
what
said,
you can do is URR చేసుకోవచ్చు కదా, urea clearance ratio.
So that is not getting adi change రావట్లేదు కదా sir. Your urea is not sir,
urea will be cleared, but creatinine is rising, he said.
Sir, urea కూడా clear అవుతుంది.
No. Most of the parameters are not getting corrected.
Urea reduction ratio.
You do a URR, sir.
So sir, అదే URR చేయడానికి there is no reduction in urea. That's what his argument is.
No, see, అసలు యాక్చువల్ గా దీంట్లో ఉందో లేదో చూసుకోవాలి కదా. అది see, dialysate urea you will measure, no?
No, urea reduction. No, dialysate urea కాదు sir. అంటే it is urea reduction ratio when it is for pre-dialysis and post-dialysis ratio is the urea reduction ratio. What you target about around 70%. But as the urea is not getting reduced, obviously, is it the hypercatabolism state that is causing the decrease in urea, or not decreasing the urea, or it is the inability?
Once see, urea is removed from the dialysate and it goes through the dialysate.
That's what I'm saying, sir. Adi effluent low, when you measure the urea, then you will get the actual urea clearance. You have to see in the effluent.
And we can see measure kada in the effluent.
నేను అదే చెప్తున్నాను, సార్ కూడా అదే చెప్తున్నాను. Effluent లో చూసుకుంటే then you can get the efficiency of the dialysis.
ఆ స్వాబ్ క్వశ్చన్ ఆన్సర్ అయిందా శ్రీనివాస్?
Question: in case of SLED, we can dose the antibiotics which are cleared in the dialysis after the dialysis. Timing, obviously, yes. When you are going for an intermittent dialysis, so obviously your dosing has to be timed post dialysis, or you have to give an extra dose when the timing is cannot be adjusted. Because of the logistics, the drugs which are dialysable or which are hydrophilic, just give an extra dose of antibiotic post dialysis, or avoid the antibiotic before the dialysis. In the case of lipophilic or which has low volume of distribution, you don't need to give an extra dose of an antibiotic.
Some people are giving post dialysis.
Depending on what antibiotic you are using.
Patient comes in shock, started dialysis immediately. They said that okay, anyway, whatever antibiotic you give, it will be removed by the dialysis, and so they are giving after dialysis. Takes 8 hours to finish the dialysis. So, what is your take on it?
Sir, Sir, most of them give in that way, but I think should not be practiced that way, sir. At least for the first day, because So antibiotic is one of the most important things should be given early for the better outcomes. So you can practice from the second day onwards, post dialysis dose. But first day we have to give
Yes.
as early
Immediately.
as possible, sir,
Yes.
irrespective of dialysis.
Yes. Questions from
you.
audience? Anna, if you want to check the efficiency of the dialysis, if it is happening to every patient, then you can have a checklist and see the, as he said, check the urea in the effluent fluid and the blood levels.
అదే కంపేర్ చేసుకుంటే బెటర్ ఉంటుంది.
There. Instead of it is not clearing or it is catabolic rate very high for all these patients.
ఏదో ఊరికనే మెషిన్ పెట్టి యూరియా అన్ను లేదా అంటే మెషిన్ పెట్టి తిప్పినట్టు ఉంటుంది ఆ ఊరికనే బ్లడ్.
That's why you have to check the efficiency of the dialysis. Right.
Thank you, sir. Thank you. Thanks a lot.
Thank you, Srinivas, for a nice presentation. And we'll close the session today. We'll come with the next session. Thank you.
Thank you, Srinivas. And